medications include buprenorphine, naloxone, Suboxone film, or generic tablets. Naloxone, both Vivitrol and the generic tablet for either alcoholism, AUD, or OUD. And this pheromone and the treatments for AUD medications. Next slide, I'll pass it on to Sonia.
Good morning, and I'll start on more key preferred OBOT manual policies. Medication alone is not usually sufficient. Same-day billing for medical and behavioral health services is strongly encouraged. DMAS also requires co-prescribing naloxone when prescribing buprenorphine. DMAS recommends prescribing naloxone for individuals with any SUD as a risk of polysubstance use. Whether intentional opiate use or unintentional opiate use, where drugs are contaminated with synthetic opioids, increases risk factors for overdose. DMAS also supports home inductions when clinically appropriate. Next slide. Telemedicine and preferred OBAT. The foundation of the preferred OBAT model is to provide the medical and behavioral health services within the same location, have in-person interactions with the member, and provide the high-touch care coordination to support the member in their recovery. DMAS also recognizes that there may be situations that telemedicine is necessary to engage the member in treatment and recovery, especially if the member makes the request. Thus, preferred OBOT services may be provided via telemedicine based on the individual needs of the member and reasons why the in-person interactions are not able to meet the member's specific needs must be documented. Next slide.
Sonia?
Yes.
Sorry to cut you off. We do have a comment in the chat. If you guys could just slow down a little bit, they're having a hard time keeping up.
Okay.
All right, thank you.
And we'll go over primary diagnoses that are covered within the OBAT. There was a public comment under medical necessity criteria section. It indicates that the patient must have a primary diagnosis of an OUD. That means that patients who are being treated here for other substance use disorders other than opiates don't get reimbursed for arts covered services, such as care coordination. We perform the care coordination services on patients with opiate use disorders, as well as other substance use disorders, and diagnoses should be expanded to cover services for providers who treat a variety of drug abuses. And to be eligible for these services, the member must be enrolled in Virginia Medicaid and meet the following medical criteria for preferred OBOT services. So they must have a primary diagnosis of SUD as defined by the most current version of the DSM, with the exception of tobacco-related disorders and non-substance-related addictive disorders. So that could be opiate use disorders, alcohol use disorders, and other SUD disorders such as cannabis, stimulants, and inhalants. And you can go to the next slide. And care coordination activities. The public comment was on supplement page 38. Substance use care coordination does not include maintaining service waiting lists, scheduling transportation rides, or periodically contacting or tracking members to determine potential service needs that do not meet the requirements for monthly billing. Care coordination should absolutely include assisting patients with Medicaid transportation because the service is horrible. Patients are stranded for hours and unable to get anywhere to help them despite repeated calls from patient and our staff. And the response is substance use care coordination must include supporting the member's medical, behavioral health, and other health care needs through facilitation of necessary referrals to help meet the overall biopsychosocial needs of the member. Substance use care coordination must include the appropriate use of and facilitation of referral to a variety of community-based support modules including a variety of different recovery and wellness pathways, peer recovery services, social services agencies, community-based resources that are appropriate to the member's needs, mutual aid supports, and other base practices. And I will turn it back over to Keyshawn.
So I will review care coordination activities. So substance use care coordination should include addressing needs beyond the member's medical status and include issues such as unstable housing, food insecurity, child care, transportation, and other social determinants of health. Face-to-face substance use care coordination is encouraged, and it should be documented. Now, if for some reason the member is unable to meet face-to-face and other forms of communication take place, such as telehealth or telephonic methods of delivery, this should also be documented within your progress notes. If the member is unavailable for face-to-face and the care coordination, then care coordination reevaluation should occur to see if that service is actually appropriate for where the member is within their treatment currently. All contacts with the member regarding the overall care plan should be documented within your progress notes as well. All efforts to educate the member regarding treatment planning, the importance of treatment adherence, and timely reporting should also be documented. Next slide, please. All right, so now we're going to talk about the comprehensive individual service plan and provide some clarifications. So one public comment we received, and it was kind of a reoccurring comment, preferred OBOTs and OTPs are required to develop an individual service plan, ISP, within 24 hours from intake. Does the comprehensive ISP that is built into the coexistent counseling program with the input of the OBOT staff sufficiently meet this requirement? So our requirements are that the comprehensive ISP shall be developed to address needs specific to the member's unique treatment as identified in the multidimensional assessment. And this is applicable for the ASAM level of care the treatment is being taken place in. The comprehensive ISP shall be documented within 30 calendar days of the initial ISP to address specific needs of the member, unique treatment, as identified within the multidimensional assessment. The comprehensive ISP must be reviewed every 90 calendar days and documented within the member's record, no later than 7 calendar days from the date of the review and the comprehensive ISP should be signed within 24 hours of that review. The comprehensive ISP should also be signed by the individuals who have participated in developing the ISP, such as the CAT-P, the physician extender as necessary. A credentialed addiction treatment professional must sign off on the comprehensive ISP if it is developed by a CSAC or a CSAC supervisee. Next slide, please. So what should be included within the comprehensive ISP? So the formatting of the comprehensive ISP is at the discretion of the provider. What we do require is that all the components as stated below are within that comprehensive ISP. So it should include the member's treatment and training needs, measurable goals, measurable objectives and recovery strategies to meet the identified needs and goals of the member, services that will be provided and recommended frequencies to accomplish the measurable goals and objectives, also the established timetable for achieving those goals and objectives, an individualized discharge plan that describes transition to other appropriate services, and it should all be based on the ASAM multidimensional assessment that was completed for that member. Next slide. Some clarifications regarding the IPOC. So the IPOC must be developed and documented within 30 days from the initial assessment prior to billing for care coordination services. The IPOC is the essential document and planning tool that should be used during the interdisciplinary team treatment meetings and is required for care coordination billing. The CAT-P must sign off on the IPOC if it is developed by the CSAC and the CSAC supervisee. Also, the IPOC should be reviewed every 90 calendar days and is subject and significant to the changes in the members' treatment goals and objectives. So as the goals and objectives of the members' treatment change, the IPOC should be updated to reflect those changes as well. If you are doing a IPOC and are providing care coordination, this does meet the requirement for the comprehensive ISP. So the comprehensive ISP does not have to be completed if the IPOC is being completed and reviewed every 90 calendar days. There were a couple of questions that I'm going to answer while we're talking about the care coordination. So care coordination is not to be used for any other disorders except opiates. So care coordination can be used for with all disorders in the OBAT setting. It's not just exclusive to opioids. So care coordination billable activity does not include transportation support, not alone. So transportation support can be provided within other care coordination activities, but if that's the only thing being provided, then no, it's not billable. Are physicians required to sign ISP2? If the physician is part of that team that develops, then they should be signing the ISP as well. But if the ISP is developed by the licensed practitioner, the physician is not required to sign if they weren't part of the development of the ISP. All right, next slide. And I'm going to pass this on to Sonia.
Okay, what should be included within the IPOC? The IPOC is a person-centered, recovery-orientated, includes all planned interventions, aligned goals, and is regularly updated as the member needs and progress change, and shows progress and/or regression throughout the course of treatment. The documentation contains, but is not limited to, the member's treatment or training needs, members' measurable goals, measurable objectives, and recovery strategies to meet the identified needs and goals, services to be provided within the recommended frequency to accomplish the measurable goals and objectives, the estimated timetable for achieving the goals and objectives, an individualized discharge plan that includes the description of the transition to other appropriate services and be based on the ASAM multidimensional assessment. And you can go to the next slide. And then the CSAC and CSAC supervisee scope of practice. The public comment was, we are seeking clarification regarding the stated on page 17. The CSACs and CSAC supervisees may not practice autonomously. Please operationally define practice autonomously, as the guidance regarding supervision from the Board of Counseling is not sufficient. And the response is, the scope of practice for a certified substance abuse counselor is defined. And it states, a certified substance abuse counselor shall be qualified to perform under appropriate supervision or direction the substance abuse treatment functions of screening, intake, orientation, the administration of substance abuse assessment instruments, relapse prevention planning, substance abuse treatment, case management, substance abuse or dependence crisis intervention, client education, referral activities, record keeping, and consultation with other professionals. They're also qualified to be responsible for client care of persons with primary diagnosis of substance abuse or dependence. And they're also qualified to supervise, direct, and instruct certified substance abuse counseling assistants. They should not be engaged in independent or autonomous practice. And by definition, autonomous means with the freedom to act independently. and I will send it over to Jessica.
Hey, Jessica, can I interject? Because we have some questions that pertain to care coordination.
Sure.
Give me just a second because I want to be mindful of the time as well. We have a question, and thank you, Keyshawn and Jessica, for answering these questions as they come in. Not sure if this one got answered, but it's from Sharon. If a patient moves from OBAT to MAT, do we need a new ISP and or comprehensive ISP? Anybody want to take that one?
So I guess a little more clarification. Are you saying they're no longer in an OBAC setting?
So they're still within our program, but they just finished like all the phases of the program, and they want to remain on the medication. So they go to MAT status, where they have the choice of, having a session or not having a session, group or no group. Are you there?
Yeah. Ashley, are you able to assist with that question? Because
So, thank you. I'm hearing my feedback, so apologize if I sound a little crazy because it's difficult to talk and hear myself. So I think of that as medication-assisted treatment would be more like ASAM level 1. So they would transition to not require care coordination or the intensity of counseling. But since I would say that technically that is a new service, that the ISP should be updated because their needs have changed. They're being closed to OBAT services and open to another level. But just want to be mindful that the Board of Medicine requires prescribers of medications for use disorder to refer individuals to counseling. So make sure that if they're not participating in counseling, that you're documenting the reasons why, because that then falls on the license of the prescriber.
Okay.
Hopefully that helps.
Yep, it does. Wait, one more thing. Can I add on to that? So in MAT, is there do they just need the ISP, no comprehensive ISP within the MAT? Is it just the ISP and renew it accordingly, like every year or something?
There still is a comprehensive ISP required, but you would follow what's in the ARTS manual for
Okay.
ASAM level 1.
Okay. Well, that's still what I got. Okay, thank you.
Mhm.
All right, Jessica, if you want to go ahead, I know we still have some other questions and I'll try to get back to those once you finish. Thank you.
Thank you. So now we're going to provide an overview of the CSAC scope of practice. So the requirements for CSAC and CSAC supervisees are referenced and based off of the requirements from the Department of Health Professions for providers who provide services such as substance use disorder counseling or psychoeducational services for members with a substance use disorder. CSACs and CSAC supervisees are not allowed to do diagnostic assessments according to their scope of practice, but they are allowed to complete a multidimensional assessment and make a recommendation for an ASAM level of care. For example, ASAM 2.1, 2.5, or 3.1. When this happens, the multidimensional assessment must be signed off or approved by a licensed professional who is supervising the CSAC or CSAC supervisee. Next slide, please. So now we're going to dive into some more of the fun stuff. The application changes that have taken place as of April 4th, 2022, in response to the OBAT model expansion. So some core highlights of note. As of April 4th, DMAS will accept only one OBAT provider application at a time unless stipulated otherwise. This is to be sure that we are completing a thorough review of each provider application and providing follow-up as needed. Providers submitting multiple applications for various sites using a copy and paste method will not be accepted by DMAS, and all applications will be reviewed within 30 calendar days with updates to be shared as needed. Next slide, please. So, we also wanted to touch base on the required documents for formal review with our OBAT review team, So we have our preferred OBAT attestation and application, which also includes the credentialing checklist, a completed OBAT staff roster indicating the licensed practitioners who are in network with at least one of the Medicaid managed care organizations, a screen print that shows the license or certification with current dates for medical and clinical staff, including proof of autonomous practice or a practice agreement for nurse practitioners and physician assistants. And then finally, a staff and scheduling plan, including a description of how you will handle emergency and on-call services and address individuals needing to start on buprenorphine outside of the prescriber's office hours. Next slide, please. Can you go back one slide for me? Thank you. So, specific to the OBAT attestation form, we are asking that providers complete the section preferred OBAT contact information, where we are asking for a name, phone number, and email address to establish contact in case we need to follow up with your organization on any clarifications to your application. Next slide, please. Secondly, and this was referenced earlier in the presentation, but specific to our model of care, we are asking that applications be completed in a site-specific framework, meaning that the application should reflect a day-to-day narrative of operations within the individual facility. As previously stated, the foundation of the OBAT model is to provide medical and behavioral health services within the same location with in-person interactions with the member and care coordinator to support their recovery. Again, OBAT services may be provided via telehealth based on the individual needs of the member and must have supporting documentation detailing the exception for telehealth. For example, transportation or employment barriers that are impeding their access to face-to-face treatment. Next slide, please. Again, continuing with the model of care, we have added additional clarification. One of note is a detailed description of the contractual relationship between the CATP and buprenorphine waiver practitioner or the organization employing the practitioner, In this particular section, we're looking to identify whether, or requesting that you identify whether this contractual relationship is an independent contractor, full-time, or part-time. Second in the model of care is requesting a detailed description of additional and medical behavioral health needs and protocols that include hospitalization as a last resort. We have also added the peer recovery role as a part of the interdisciplinary team, and this can be documented as needed. And finally, we are requesting a description of comprehensive treatment and integration for other physical and mental health conditions on site or through collaboration with providers to ensure reasonable geographical access to the member. Next slide, please. So now we're moving to the daily schedule, and the following revisions have been added. So, for example, we are asking that the method of service delivery be indicated with the staff member's name and credentials. You can also add residents and supervisees to this list. And more specifically, we are asking for staff members who will be on site to be listed first, and then providers who will be providing services via telehealth listed afterwards. Secondly, we have updated the MAT induction box to state medication induction to support the expansion for the OBAT model. And we are also asking in that section that when you're completing the daily schedule, that you indicate the days of the week for your physicians, nurse practitioners, and physician assistants only. And then finally, we've added a box for peer recovery specialists to provide additional details of their duties and responsibilities within the OBAT. Next slide, please. So to match the daily schedule, we have made similar updates to the OBAT staff roster. So again, the service delivery column is added to indicate who will be providing services on site versus telemedicine. Everything else remains the same: provider name, degree, licensure, NPI, and DEX numbers if indicated. Next slide, please. So as of April 20th, 2022, there are 196 OBAT sites included, there are 196 approved sites within the Commonwealth. 61 of those are in the Southwest Virginia and Tennessee region, followed by 32 in Northern Virginia, 29 in Tidewater, and 26 in the Central Virginia area. Next slide, please. And I will turn this over to, I believe this is Keyshawn, correct?
Yes, we wanted to provide you all with an overview of the ARTS 4-year evaluation. This looks at prevalence of SUD diagnoses. So just over 100,000 Medicaid members had a diagnosis of SUD in state fiscal year 2020. That is an increase of almost 30% from the state fiscal year 2019. As in prior years, OUD was the most frequently diagnosed SUD in state fiscal year 2020 with about 40,465 members, followed by AUD with about 37,647 members. Cannabis followed next with 27,290 members, and stimulants which include the use of methamphetamines, with 22,493 members. Stimulant use is especially concerning, given that almost 50% increase in Medicaid members with this diagnosis between the fiscal year 2019 and 2020. During the same period, OUD prevalence increased by 33.2%. AUD increased by 34%, and cannabis use increased by 38%. There was also a 58.4% increase in diagnoses related to hallucinogens, although overall prevalence of hallucinogens is still very low, only 822 members with diagnoses within state fiscal year 2020. Next slide. All right, so here we have entered into the question and or feedback portion. So I'm going to go through and try to clarify some of the questions within the chat. I believe we've kind of tackled most of them, but one thing that I want to go back and ensure that we make clear that, so when we implemented the OBAT, the OBOT model is no longer in existence. So it's now OBAT. So that's office-based addiction treatment. So for all SUD diagnoses that are treated in the OBAT, you are able to bill all the same billable codes as before, because now it's open to all SUD with the exception of tobacco use disorder. So yes, you can bill for care coordination, you can bill for the counseling, you can bill for all of those things in the OBAT because it's not the OBOT anymore. I hope that makes sense. So it includes all those diagnoses. I know AUD was being asked about. Yes, you can bill the care coordination code for the treatment of AUD in the OBAT.
Thank you. That's what I was really, really struggling with. The difference between the OBAT G code, and I wasn't understanding. Anyway, I think I got it. Both of them can be billed as the G code. OBOT,
Yes,
OUD and AUD and any other SUD.
yes. So
Okay.
remove the OBAT. So it's now remove the OBOT because it's now OBAT.
I got it. I got it. Thank you so very much for your patience and helping me understand that.
Oh, you're very welcome.
Okay, so
Okay.
Keyshawn, if I could jump in and provide some clarification on the application process. If your OBOT was previously approved prior to the expansion to the OBAT model, you do not need to resubmit an application for approval. The only time you would be required to submit an application is if you were planning to open a brand new location, and then the attestation, the staff roster, and the credentialing checklist with all the supporting documents would be required for submission.
And Jessica, I see a question about, do we need the daily schedules from previous OBI sites? We don't. We just need the daily schedules from the new sites that you're applying for.
Yeah, so in essence, if you were an approved OBAT, you are now an approved. If you were an approved OBOT, you are now an approved OBAT, and you do not have to resubmit any paperwork for your previously approved OBAT to now be considered OBOT, to now be considered OBAT. Unless you are applying for a new OBAT location, that's when you submit an application.
And then I see another question about if we are an existing OBAT and we need to add more than one provider to our location. So this is actually referring to the staff roster, correct, Dr. Hartman?
Yes, that's correct. Right at the same location, we might have an influx in the summer of new providers, could be 2 or more. And I was concerned about having to limit, this is just a simple process of, notifying the MCOs and getting them credentialed and so on. Do we have to limit it to 1 provider at a time, or does that restriction not apply to that case?
So if there are changes to your staff roster, for example, if there's a provider leaving or a new provider coming on, you would just redo the staff roster and submit that to the managed care organizations whenever you need it.
For as many providers as we are at?
Correct.
Okay.
Jessica, there's another question. Barry did have her hand raised and she put a question in the chat. Is there a reason that we would need to reapply for a new physical location even when our model is the same?
Especially if we're transferring providers who are already working in one office to staff the new office.
So if that is considered a brand new location, we would still require that process to happen just for, tracking purposes. And because we have a directory posted on our ART's webpage for members and providers to access if someone needed to refer a member to another OBAT in their area. So does that answer the question?
Yeah, thank you.
Okay, you're welcome.
I see Samantha has a question regarding the IPOC versus comprehensive ISP when billing substance use care coordination. Samantha, are you able to come off of mute?
Yes, I was wondering, because I know it says billing for care coordination, you use an IPOC. We don't use an IPOC, we use a comprehensive ISP. I didn't know if we need to include the IPOC form since we are billing care coordination, or if the comprehensive ISP is, comprehensive enough to not have to include the IPOC form inside the care coordination. We do a 30-day review because we are billing care coordination, but I didn't know we actually need to do the actual IPOC in addition to the comprehensive ISP.
So when you're doing, go ahead, Keyshawn, I'm sorry.
Sorry, Jessica, I didn't realize you were about to answer. You can answer if you like.
Okay, so when you were doing the monthly reviews for the interdisciplinary plan of care, and there are no changes within that 30-day review, it can be documented as a progress note in the member's record. However, the comprehensive ISP should be updated on a quarterly basis. Does that clarify?
Kind of. I just need to know whether or not I need to do the IPOC form, because we are doing quarterlies and we're doing a 30-day review because we have to do a quarterly for every ISP. And then we do a 30-day review because we're billing care coordination. I didn't know, because she does a progress note. I didn't know we had to do an IPOC. I saw the DMAT IPOC has different things on it that's not in, that kind of covers within our ISP, but I didn't know she actually had to use that form with the 30-day review.
Okay, so you don't have to do the IPOC exactly every 30 days. Again, it could be a progress note, but as long as the elements of the IPOC are there during that 30-day review, even though you're putting it in a progress note, that is still acceptable.
Okay, thank you.
And so if I can just clarify a little bit with that. So if you're billing SUD care coordination, the IPOC is a required document to support your billing of care coordination. So while it doesn't have to be our exact IPOC form, all the requirements within the IPOC are required to be documented, and you should list it and put that it is the IPOC. Now, to reduce your paperwork requirements, if you are doing the IPOC, because it does include all the elements of the comprehensive ISP, you don't have to do the comprehensive ISP. You can just use the IPOC as your form that you're using. So that covers you for billing of your care coordination and also your paper requirements for that quarterly comprehensive as well.
Okay. Okay. I'll bring that back to the team so they can make a decision on which one they want to do. Thank you.
You're welcome.
So I see that Dr. Germano has a question, and it says, if a patient is treated for stimulant use disorder as the primary diagnosis, will ARTS rates reimbursement be approved for higher ASAM levels of care, such as 2.5 or 3.7? Ashley, would you like to jump in on this if you have some insight?
Thank you, Jessica. So yeah, the stimulant use disorder is always been allowed with the ASIN level 1, 2.1, 2.5, 3 and above. The only service level that was limited to opiate use disorder prior to March 1st was our OBOT. Great question.
When I admit patients to the hospital on a 3.7 level, and if I were to give the reason as being stimulant use disorder, typically they turn the patient away because it's not thought to be, won't qualify for reimbursement. And, I often run into that problem. I didn't know if that had changed or if I misunderstood it to begin with.
No, you are correct. So ASIN level 3.7 can be in a psychiatric unit of acute care hospital, a residential facility, or a freestanding psychiatric hospital. So if you're getting told that Medicaid will not reimburse for a primary stimulant use disorder, as long as it meets the ASAM criteria for that level of care, they can provide and bill for that. They would have to be licensed by DBHDS as an ASIM level 3.7 as of July 1st of 2021. But if you're running into issues with health systems or other providers with that, if you want to share the agency and a contact person, we can follow up.
Perfect. That was my next question because I know I'll get some pushback when I say that.
Yes, absolutely. And you've got the team on today that will help navigate those concerns.
Thank you.
You're welcome.
You can go to the last slide so that they can have the contact information. So here we would ask you to send any of those concerns, the one that was previously mentioned that you were discussing with Ashley, you can send them to stud@dmas.virginia.gov, and we can follow up through the stud mailbox, which is our provider help mailbox essentially, to get those questions answered. Also, someone asked a question about the diagnosis. What is the list of diagnosis for SUD? We do go by the DSM-5. And what's listed in the DSM-5, again, with the exception of tobacco use disorder.
My understanding is DSM-5 was, even though it's not a substance, going to include gambling disorder as one of the substance use disorders.
That is not included as well. So it's not the exception of tobacco use disorder and any disorders that are not substance related.
Thank you.
You're welcome.
And if it's helpful, I just put a link to the ICD-10 free lookup. And so you can see the categories of the ICD-10 codes and pick ones that are relevant to substance use disorders.
And I did see another question about the multi-dimensional assessment. It says, can you bill for the multi-dimensional assessment separately in the ARS program, or is that covered by the G9012 code, or can the ISP also be billed in the first month? So, David, just to make sure that we are answering your question clearly, do you mind taking a few seconds and providing some clarification for us?
Not at all. I guess so. When you first, the patient comes in, you're completing the multidimensional assessment, and at the same time have the requirements of completing the ISP. Are obviously, the multidimensional assessment plays a key component in developing the ISP. Are they separate and distinct that can be billed for that month, or is one all encompassing of the other?
Can I ask if they're billed one all encompassing of the other? If you do the comprehensive assessment and then the ISP all in that same day, do you tack on the units that it takes for time to actually put the ISP together aside from the comprehensive assessment?
That's it. That's exactly my question.
Okay. So the multi-dimensional assessment is mainly used to determine medical necessity for a level of care. So we require that assessment be completed within 30 days. Well, the assessment be completed and then the member be placed and treatment be initiated within 30 days. Regarding the initial ISP, once the member is admitted into services, the initial ISP is required to be completed and signed off within 7 calendar days of admission and placed into the member's record. And then the comprehensive ISP is required within 30 days post admission. Does that clarify?
Well, actually, so what we do is we do the ASAM assessment, 6 dimensions. While the patient is in with the medical provider, we put together the ISP and we take it to the doctor and they go over it with the patient. And afterwards, we go ahead and get that signed because that ISP has a 24-hour turnaround time. And we know we're not going to be able to get that patient back in. So we do both of those things within the same visit. So I'm asking, can we build the additional units that it takes, like say it takes 30 minutes, so 2 additional units within that comprehensive assessment, the ASAM assessment. So 2 different things happening all at the same time.
There is not a billing code for the multidimensional assessment. It is to be completed as part of treatment for that ASAM level of care, as well as the ISP. So there's not billable codes that are part of the treatment. Ashley, I don't know if you have any further clarification to add to that.
But isn't the comprehensive assessment billed, it would be billed as an individual session because you have to get paid?
We do not get appropriations from a General Assembly to reimburse for the multidimensional assessment. It's currently like a component of a service. But those that are doing the multidimensional assessment that the individual doesn't meet a level of care that they provide, there's currently no billing component to complete that. That is something that we are pursuing each year with the General Assembly to get a separate procedure code and reimbursement rate for the multidimensional assessment.
Could I ask a couple
As
of
we
questions?
are wrapping. Sorry. As we are wrapping up today's training and presentation, we do ask that if there are any additional questions or follow-up, to please email us at sud@dmas.virginia.gov, and we'll be more than happy to make sure that we answer your individual questions there. We thank you for your time today. We thank you for the opportunity to provide this training to you, and we thank you for providing the great services that you do to our members. The PowerPoint, if you would like a copy of the PowerPoint, please email us and we'll be happy to send it to you.
And it will also be posted on our website as well. So please be on the lookout for that in the next couple of days.
Thank you all.
Thank you.
Have a great rest of your day.